Hi, hello, welcome back. So today we'll be discussing about ENM coding questions with answers part 3. As I said, we have totally 100 questions. So if you haven't watched the previous part, that is part 1 and 2, I'll share the link here so that you can go through it and make sure you're taking note of all the questions so that you can prepare whenever you get time. So let's get into the video. Welcome to Learn with Dhanya. In this video, we'll be talking about the most important interview questions for freshers, medical coders, and how to prepare. So these are the questions which are frequently asked during the interview, and the main important thing is like all the questions are given in detail. So the first question is how PFSH is used in ENM level. So in this, problem focused, expanded problem focused, detailed history and comprehensive history is there. In PFSH, problem focused is not required, as well as expanded problem focused also PFSH is not required, where in case of detailed, any one will be present, whether it is past or family or social, and in comprehensive, all the three will be present. Second question, what are the exam component in ENM coding? The exam is the second key component of ENM coding after history. It involves a physical examination of the patient. It documents the body areas and organ system examined. The extent of the exam helps to determine the ENM service level. And when you come to the level of exams, we have 1995 guidelines as well as 97 guideline. So in 1995 guideline, problem focused means only one body area or organ system will be examined. Expanded problem focused, limited exam of affected area plus other symptomatic area. Detailed means extended, that is affected area plus other related area more in depth. Next question, the difference between 1995 and 1997 guidelines. Both are the rules for ENM coding. The history and medical decision making are the part in both. The only difference is exam part. Like what is differing is in 1995 guideline and 1997 guideline is the examination. So, in 1995 guideline, the exam is based on body area and organ system. Example, if the doctor checked the heart, lung and abdomen, you just count those system. In 1997 guideline, exam is based on bullets instead of just naming the system. For example, examine lung, the doctor has to write exactly like listening to the breath sound, checked the effort of breathing, inspected chest wall, like that. In detail, it will be given. If in one line we have to say means 1995 is organ system and body area oriented, whereas in 1997 it is bullet point. Imagine like in 1995 we will say like I studied science, maths and English, whereas in 97 in science what all you studied, like that in detail, in depth it will be given. That is the only difference here. Next question, 4 types of physical exams. Problem focused, expanded problem focused, detailed exam, comprehensive exam. In problem focused, limited exam of the body, like only that particular part will be examined, like what we are complaining. And expanded problem focused, the limited area plus the related symptomatic area will be examined. Detailed means affected area plus related organ in detail. And what is medical decision making? Medical decision making reflects the thinking process of the physician, how they assess the patient condition, decide on test, interpret results and plan the treatment. There are 3 elements of MDM. MDM has 3 parts, that is number of diagnosis, amount of complexity of data and risk of complication, morbidity or mortality. These are the 3 elements, and when coming to the 4 levels of MDM, based on those 3 elements, MDM can be divided into 4 levels. First one is straightforward, second one is low complexity, third one is moderate complexity and fourth one is high complexity. In straightforward, minimal problem, low complexity, limited problem, moderate complexity, multiple problem and high complexity, many problems will be there. 3 elements of MDM. The 3 elements of MDM are number of diagnosis or management options, like how many problems does the patient have, and amount and complexity of data reviewed means test records, labs, imaging, discussion, those things. And risk of complication, morbidity or mortality, how risky the patient condition and treatment plans, like whether it is low, moderate or high. And when coming to the level of MDM, first one is straightforward MDM, which means the only one minor problem will be there, no data will be reviewed, there won't be any risk. Second, coming to the low complexity MDM, same like limited problem will be there, but any one data will be reviewed, risk will be low risk. Third, next one is moderate complexity MDM. Here the patient will be having multiple problems and data, 2 or more data will be reviewed, risk will be moderate. In high complexity, extensive like life-threatening conditions will be there, and most of all the lab tests will be done for the patient, and the patient will be in high risk. How is MDM, that is medical decision making, determined? Medical decision making is based on 3 key elements. First one is number and severity of the problem, like how many problems does a patient have, how serious they are. And second comes amount and complexity of data reviewed, like what type of test records or reports is being reviewed by the doctor. Like if it is no test done, then it is simple. If more tests are done, then it is complex. And risk of complication, morbidity or mortality, how risky is the patient's condition or treatment. If normally a medication is given, it is low risk. Deciding for surgery, it is high risk. So MDM is based on level is chosen by highest of 2 out of 3 elements. If 2 elements meet, then it is moderate. If 2 elements meet high, then the MDM will be high. Example, MDM is determined by 3 factors: number, severity of the patient problem, amount of complexity, risk of the patient. So the level of MDM is assigned based on 2 out of these 3 elements. Any 2 is meeting, like if it is moderate, you can go for moderate. If it is high, you can go for high. What is time-based coding? Time-based coding is when the evaluation and management level is chosen based on the total time a provider spend with the patient on the data of service instead of history, exam or medical decision making. Normally, E&M codes are chosen by history plus exam plus medical decision making. So below I have given few examples. So based on the time, like you can choose the code. What is time used in? When is time used in E&M coding? Time is used when the provider spend most of the visit in counseling or coordination of care. Situations where time is used as counseling, coordination of care, etc. Below I have given an example. You can go through it, make a note of it. So that's all about today's question. So next we'll be continuing with part 4. In that again 10 questions will be discussed. So if you are looking for interview guidance, training or placement support, you can register with us. We'll completely help you and assist you throughout the process. So that's all about today's topic. If you haven't subscribed, please do subscribe, and if you find it useful, please do share it with your friends also. Thank you so much. Thank you so much for your time. Take care. Bye-bye.